Thank you, Dr. Nanga, and thank you for inviting me here. I think I don't have much to say after some very excellent talks on all the imaging devices. So what are we trying to, I've been given a very difficult topic, what are the problems with structure and functional studies in glaucoma? What are we comparing? We're not comparing like for like. We're comparing visual fields, which are retinal sensitivity thresholds to a structural, a retinal structure as such. I think this is going to be a little bit of a repeat, and I'm making some very sweeping generalizations here. The OCT should not be used to detect glaucoma in a population, and of all the OCT parameters, the optic disc parameters are probably the least useful. So based on this premise, I'm just going to go quickly through some interesting work which is there in the literature. About 7 years ago, we looked at the superior hemifield visual loss in glaucoma, and we compared it with what is happening on the macula. And we found an excellent topographical relationship. The macular volume almost always decreased if you had central field loss. But when we tried relating visual field sensitivity to the macular volume loss, we got a very poor correlation, and that's when I stopped working on OCT, stopped doing research on OCT. Because the R squared, which is the amount of variability, it was only in about 1. That means it only explained 10% of the variability in the correlation between visual fields and macular volumes. Robert Weinreb and Medeiros, who are the experts and the world-renowned experts in this field, found something similar. When they looked at optic disc parameters, they found a very poor correlation between the visual field sensitivity and different optic disc parameters. When they looked at the RNFL, they found a slightly better in the inferior temporal and superior temporal. So I tell everyone, when you're looking at an OCT, look at the inferior temporal and inferior temporal sectors. That's where the action is. Do not look at the temporal. It has very correlation with glaucoma as such, and the nasal. But when they looked at the macular volumes, they found the best correlation, approximately 0.2 to 0.3. But even then, they only managed to explain 20 to 30% of the variability between inner macular thickness and visual field sensitivity. So why do you have this very poor correlation? Firstly, visual fields. There's a tremendous test-retest variability. Your visual fields are designed to detect early visual field loss. Once you start getting depths of field loss, once you go over 15 decibels, you'll get a lot of variation in the readings you get, because the retinal sensitivity varies quite a lot from time to time. 24:2, you're missing the central 3 degrees, and the test points are 4 degrees apart. And then there is, the redundancy in the visual pathway as such. So if you look at a 24, you see a small paracentral, but if you see the correlation, just roughly, if you look at it, you can see there's a far more better correlation with 10:2 visual fields than with 24:2. This is a lady who has advanced advanced cupping, but if you look at the visual fields, they're practically normal in the right eye. In the left eye, she's got an early arcuate and nasal step as such. If you look at the OCT parameters, in the left eye, in the inferior quadrant, she's almost reached the floor. That means her retina is not going to thin anymore. Yet she has a normal superior visual field. There may be segmentation errors, but actually they weren't. We looked at this very carefully. If you look at this eye, this is an African female, with a young African female, and you can see inferior field loss, but if you do the red free, you'll also see a superior field loss. The OCT, the only factor which was abnormal was the macular volume. But if you look at her retinal nerve fiber layer thickness, it's 138. This is way above the upper limit of normal in the normative databases. And in the left eye, it is even higher. So this is a person with a very thick nerve fiber layer who probably will, and probably lots of ganglion cells, who will probably lose a lot of ganglion cells before she actually gets a field loss. The seminal work on retinal ganglion cells and visual field sensitivity was done by Harry Quigley and Ronald Hurwitz in the late 90s. Hurwitz actually trained monkeys to do visual fields. And what he showed was that early on, you get a little bit of field loss with a large number of ganglion cell loss. But as the disease goes on, you get for given number of ganglion cells, you don't lose, you lose far more visual field. And it was a sort of a log-log relationship between visual sensitivity and ganglion cell loss as such. Quigley's group did that in normal retinas, and they found, as mentioned before, that the ganglion cell counts vary by about a factor of 2 between individuals. You need to lose at least 25 to 30% before you get any field loss. The study showed that the correlation between visual field loss and the number of ganglion cells was about 0.39 or 0.4, which is a very good correlation. So they managed to explain 40% of the variation as such. And when they looked at the number of ganglion cells and the predicted versus the real mean deviations, these are sort of post-mortem eyes. They found that there was a pretty good correlation, but with a wide standard deviation as such. This is a classical diagram. I won't go through that. But just looking at the retinal ganglion cell, this is an RT-view 3D image. If you segment it, you will find that in a person who looks like, you will see that the visual field, the ganglion cell loss is more marked if you just segment the inner retinal layers, and I always liken it to a donut. If you chomp a bit off, you lose a bit of volume. So getting this concept in mind that you're losing macular volume with glaucoma, Weinreb and Medeiros once again tried to derive retinal ganglion cells from the previous studies for visual fields and from macular volume. It's a complicated formula you can look up in the reference, but they combined the two, and they found that you can actually get a pretty similar value whether you calculate the number of ganglion cells either from the visual field mean deviation or from the macular volume, inner macular volume. So they came up with these estimated RGC counts. The paper claims that you can differentiate between early ocular hypertension, early glaucoma, and glaucomatous visual field loss. But if you look at the overlap, there's a tremendous overlap. So you have to be careful, again, in interpreting this data. What they found was that retinal ganglion cell counts and visual field mean deviations were related in an exponential or log fashion, but the nerve fiber layer to mean deviation relationship was linear. And as I mentioned to you, the floor effect was about 57 micrometers. So after that, you can, in a glaucoma patient, it's probably not useful to do any more OCTs. Visual fields is a better way to follow them up. And as you can see, early on, you can lose 40,000 ganglion cells and just get probably about 1 or 2, you can get about mean deviation loss of about 1 or 2 decibels, but further on, for the same loss, you can lose almost about 10 to 15 decibels. So Medeiros then came up with a combined structure function index, which he felt worked better than if you use either visual field or OCT parameters. The overlap here is less, but it's still significant, nevertheless. And these retinal ganglion cell loss and CSFI have been used in clinical studies, and they are picking up progression, more progression than both visual fields or OCT progression. But there's a big question mark to the number of people who are being picked up by these, like, for example, the retinal ganglion cell index loss, whether these are false positives or these are truly patients who are progressing. I always like to point out that there are more normals than glaucoma patients. So when you get so even if you have a test which is false positive rate of 95%, you're still, you will still have a 5:2 probability that the patient is normal rather than glaucoma. So keep that in mind as such. So are they useful clinically so far? Earlier diagnosis, early detection of progression. I think the main value of combining structure and function is you get corroboration of your findings, your clinical findings, your visual field findings, and your structural findings. Just one example, 54-year-old ocular hypertension swims with me. His intraocular pressure is all over the place. He takes his medication every now and then. So we get very different values. Visual fields have not progressed significantly. This is a printout from what's known as Medisoft. It is a sort of database. All our patients' data gets entered. It's brilliant because it shows us exactly what's happening in a snapshot. These are his last visual fields. If you look at the OCT right eye, you can see that there is a significant curve on of the RNFL analysis over time. He is losing some nerve fiber thickness. More so in this eye, and you can actually see that there is loss in the inferior temporal quadrant. So we probably have to treat him better than we are right now. Progression, we are part of something known as the UK glaucoma treatment study, which is the first study which has shown that treatment for glaucoma actually helps. This was a randomized double-blind controlled study. Part of the study was imaging. We did a lot of imaging, HRT and OCT, and both have actually now shown that you can pick up progression purely by structural means. The Canadian glaucoma study has for the first time correlated HRT, slowing down on HRT disc loss to intraocular pressure reduction as such. And you can see here that again macular volume is being lost as such. How does it compare to function? You can see that in most cases, function structure is being lost before function. In this patient, it took about 2 years before the visual field loss became apparent in a person who was losing the inferior temporal quadrant. What is frightening is that she lost half a nerve fiber layer as such. I'm going to quickly end here, and I think Dr. George has very nicely covered the false positive bit. So as such, attempts to correlate OCT-based structural and visual field parameters is limited by significant variability in both the tests. Estimated combined retinal ganglion cells is probably a way ahead. It has given us a better understanding, but remember it's in cohorts of patients, not in population studies as such. So we got there, we're not at a blind end, we are moving ahead as such, but when you look back and think how we were 15 years ago, I think we've made tremendous progress. Thank you very much.